Good afternoon for everyone. My name is Eszter Szőke, and my PhD thesis title is Aspiration in the Tracheostomized and Critically Ill, Diagnosis and Prevention of Complications Associated with Dysphagia. I'm a speech and language therapist at Kiskollar Semmelweis Hospital at Neurology and Intensive Care Unit and at Semmelweis University at Department of Intensive Therapy. My vision is that speech and language therapists and physicians working side by side for their patients, and my mission is delivering evidence-based speech and swallowing diagnosis and therapy for all patients. You can see there my three ongoing projects. The first one is a systematic review and meta-analysis. The second one is drafting of a prospective observational study protocol, and the third one is a survey initiation. About the background, dysphagia is common among critically ill and neurological patients with a high rate of aspiration, which can cause pneumonia and prolonged hospital care and slower recovery. It's very important that if screening for aspiration lacks, that pneumonia incidence is higher. You can see there are several methods for diagnosing dysphagia. There are invasive and non-invasive ones. The invasive one is the FEES, the Fiberoptic endoscopic evaluation of swallowing, which can provide us real-time visualization about swallowing, but it can be uncomfortable for the patient and it requires specific knowledge. About the modified Evans blue dye test, it's a non-invasive test for tracheostomized patients when the patient gets colored liquid or food, and if we can see through the cannula, it means that the patient has aspiration. And the GUSS test is for stroke patients, and GUSS intensive care units for patients who had extubation. My first project is comparing the modified Evans blue dye test to fiberoptic endoscopic evaluation of swallowing for diagnosing aspiration tracheostomized critically ill patients. And about the background, as I told, the FEES is an invasive method and the blue dye test is a non-invasive, and the missing link is the quality of the evidence of the blue dye test versus FEES in tracheostomized patients. And the aim is defining whether blue dye test or FEES is the most reliable and feasible diagnostic method in tracheostomized critically ill patients. The clinical question is blue dye test as accurate as FEES for assessing aspiration in tracheostomized critically ill patients. I use PEER framework. The population is tracheostomized critically ill patients. The index test is the blue dye test. The reference test is the FEES, and the diagnosis is the aspiration. My hypothesis is blue dye test is not inferior to FEES in diagnostic accuracy. We did our systematic search in 3 databases. You can see that the search key, and finally we had 6 eligible articles. The first outcome is the sensitivity of the modified Evans blue dye test. You can see there are 6 articles. All of them are observational studies, and the sensitivity of the blue dye test is 0.64, and the outlier is the Phil and the Warnecke. We found that they performed the test at the same time. The specificity of the blue dye test is 0.89, and the Belawski is the outlier. Except for Belawski, the patient were weaned off ventilator. The positive predictive value of the test is 0.95, which means that blue dye test is reliable to confirm to positivity of aspiration, but the negative predictive value is 0.59, which means that it's not reliable. The study strengths are that based on the data, we can directly inform bedside practice and immediately translatable into practice. But the limitations are it's a relatively small and heterogeneous patient population. Our conclusion, we have implication for practice, so if the modified Evans blue dye test is positive, it means that the patient can be fed orally and we can decannulate the patient. so we can find any alternative feeding methods, and we suggest that the cuff should be kept inflated. If the modified even blue dye test is negative, we should use the FEES, and if it's positive, there are the same steps as blue dye test, but if it's negative, the patient can be decannulated and fed orally. But due to the significant differences in the methods, consensus on best clinical practice is urgently needed. We will submit the manuscript to clinical nutrition. My second project is validating the Guggling Swallowing Screening test in tracheostomized patients. As I told you, the GUSS test is for stroke patients to diagnose dysphagia, and it's easy to use by nurses, speech therapists, or other experts. As you can see in the picture, in the test we can give the patient several amount of food and liquid and several consistencies, and if we see that the patient coughs or voice changes, it means that the patient has aspiration, so we decide we feed the patients or not. The missing link that are critical care nurses and physicians as reliable as speech and language therapists in GUSS test, and the second one is GUSS as reliable as blue dye test for assessing aspiration and tracheostomized critically ill patients. The aim is assessing inter-rater reliability of the GUSS at the intensive care unit, and the other one, the assessing reliability GUSS as compared to blue dye test in tracheostomized patients. The clinical questions are, is the GUSS test as reliable regardless of the professionals applying it, and is GUSS as reliable as blue dye test? You can see the peer framework. The population is tracheostomized tracheostomized patients weans from respirator. Index test is the GUSS test performed by the intensive care unit nurses and physicians, and the reference test is the blue dye test and FEES performed by speech and language therapists. And the diagnosis is the aspiration. Our hypotheses are the intensive care unit nurses and physicians as reliable as speech and language therapists in GUSS, and GUSS is as reliable as blue dye test. The clinical implication is less need for invasive tests, better cooperation between physicians and non-physicians. You can see the eligibility criteria. We include tracheostomized adult patients weaned off ventilator, and the exclusion criteria is pediatric patients and who is unconscious. The primary outcome is aspiration diagnostic accuracy, and the second outcome is inter-rater reliability. My third project is developing consensus on the application of modified Evans blue dye test. As we know, the blue dye test is a simple, non-invasive and inexpensive method. It's not require prior knowledge like an endoscopy, and when fluoroscope or fiberoscope is not feasible, we can use this. Our aim is to determine the appropriate method for performing the modified Evans blue dye test. You can see there in the table there are several methodological assessment of the studies, and we will organize the questions about, for example, standardization, respondent characteristics, the modification, documentation. So now we are working on the questionnaire, and we are working on it. So in summary, these are my 3 ongoing projects, and I would like to thank you for your attention.
Congratulations. I have a question regarding your first project. What's your own clinical practice with the blue dye test, and what steps can be done differently?
Yeah, so the blue dye test has not standardization. So in my practice, I use it every day when we have tracheostomized patients. First of all, I always check the patient can or not swallow their saliva if they can. After that, with deflated cuff, I started the blue dye test. So first of all, I always start with pasty consistency with food, but with a small amount, and then go for a bigger one. And after that, if they not aspirate, I follow it with fluid, with first of all 1-2 milliliter, after 5, 10, and more. So, and if I can see that the patient, I see in the cannula the blue dye, or it means us that they had aspiration.
Thank you very much.
I wanted to ask almost the same question that regarding your first project, the conclusion is it different from your everyday practice, or you can follow this one, or you have already done this guideline for?
We don't have a guideline because as we see in the articles, they use several course distances. We don't have steps how can we do the blue dye test, so this is why we want to consensus about that. So it depends on the speech and language therapist now how they perform the test.
Okay, thanks. Any questions?
if I may, I think your project is, according to clinical relevance, maybe the most relevant of what I've heard today.
Thank you so much.
These are actually the patients that can die if something goes wrong.
Yeah.
And they usually die. Now, what I particularly liked is your suggestion for clinical practice. Do that. If the result is that, then okay. If not, then do that. Yeah. But I'm a bit concerned about your selection of the journal. Why clinical nutrition? Why would that be relevant? Because people that read clinical nutrition, they don't handle these patients. This is either general internal medicine or critical care or intensive care. So why don't you go elsewhere? Like JAMA Network Open, I don't know what.
Telling you the truth, there are not many articles, so the evidence is, I think, but we're thinking about that, so why?
I would definitely go elsewhere. Otherwise, all perfect. Thank you.
I discuss with my supervisor. Thank you so much.